Our group is growing. Mhm. I need to make some folks co-hosts to be able to help me let people in. Robin, can you make Hina and Samaya co-hosts so they can help with letting folks in?
I can't. Oh, look, I can.
Oh,
I'm going to take back host for just a moment and then
okay.
I'll do that.
I was right-clicking and not having success, so thank you. Okay. I imagine we will have other folks join us as we go, but I'm going to suggest we go ahead and get started in the interest of time because there's a very full agenda that we have for today. Look forward to the discussion, though. Really, I think we'll be able to get through quite a bit. I'm going to review the agenda really quickly. My name is Carrie Bruffett. I'm the Vice President for Policy at the Kansas Health Institute, and we are facilitating this working group, but this working group belongs to you, the members. So I'm going to try to move us through the agenda pretty aggressively, timeline-wise. We have a lot to do, but if there's any moment where we really need to spend a little extra time, feel free to push back and stop me from rushing us. But we do have quite a few items to get through. You will notice we will spend a few times here at the a few minutes at the beginning of the meeting talking about the behavioral health workforce recommendation and sort of reflecting on some of what we heard at the special, those of you who participated in it at the special committee meeting last month, a couple weeks ago, and whether you want to have elements of what you heard there reflected in the behavioral health workforce recommendation as a revision. We will then spend some time looking at the survey results and kind of where you all were thinking the consensus and for revised and significantly revised and new recommendations. So thank you to those of you who completed that survey. We know that was quite a lengthy survey compared to some to have to complete. So we really appreciated that. That really helps us. And then we'll talk a little bit about some potential other revisions that had come up in other meetings but hadn't been proposed to MAT, medication assisted treatment, and foster homes recommendation, and then just check in super quickly on two recommendations that we think are considered pretty simple revisions that were complete. Our intent is not to revisit language of any of the recommendations that have already been worked out, unless there's a really driving intent to. Now, there's some where we're explicitly going to be looking at language, looking at potential revisions, for example, the behavioral health workforce. But others, we really want to just dive into the prioritization. What are the things you want to capture in the report to share with the special committee? I will next ask folks around here to introduce themselves, just do a really quick introduction. Remind you all, whenever you speak, either for introductions or making comments, please introduce yourself so those folks who are watching on YouTube or on Harmony can identify you as well. And a reminder, their meeting commitments are to come ready to discuss and compromise, be succinct and on topic, but don't hesitate to ask those clarifying questions. And we will start and end. Well, we're starting more or less on time, but we're going to end on time. So we're going to work our way through quite a bit, and I appreciate everybody's time. So I'm going to stop screen sharing and for a moment, and then we'll just dive right into it after we do introductions. I will call out people just in the order I see them on my screen. So Greg.
Yes, Greg Hinnon with 4 County Mental Health Center.
Wes.
I'm Wes Cole with the Governor's Behavioral Health Services Planning Council.
Andy.
Andy Brown with ks, Commissioner for Behavioral Health Services.
Brenda.
I think there's two of us, but this is Brenda Soto with DCF, and I am the Director of Medicaid and Behavioral Health.
There are two Brendas. Other Brenda.
Representing Brenda Landwehr, 105th District, West Wichita.
We'll call you Brenda with the hat.
Okay.
Or Representative Landwehr or Madam Chair, either one of those. Cassandra.
Hi, I'm Cassandra Sines, and I am a parent advocate.
Deb.
Deb Stidham, Johnson County Mental Health, and representing the Kansas Association of Addiction Professionals.
Gary.
Gary Hinault, Behavioral Health Director, Youth Services, ks.
Kelsey.
Kelsey Torres, Behavioral Health Consultant, and KDHE Bureau of Family Health.
Lisa.
Lisa Southern, Compass Behavioral Health.
Sarah Fertig. You're the only Sarah.
Hi, everybody. Sarah Fertig, State Medicaid Director, KDHE.
Rachel. Oh, I think we lost her.
I forgot to unmute.
Oh, no, there you are. Okay.
It's always someone. Rachel Marsh with the Kansas Children's Alliance.
Dr. Warrens.
Hey, Will Warrens, Sunflower and Kids Still See in Olathe.
Senator Fagg. Oh, you're muted.
Can you hear me now?
We can.
Okay. Hello, everyone. My name is Michael Fagg. I'm with District 14 State Senator.
All right. Did I miss anybody from the working group? We also have some folks from KHI colleagues, Samaya Parra-Kramer, Hina Shah is also on. Gosh, we probably have some other folks. Megan Leopold from KLRD and Scott Abbott from the Office of the Revisor. If you have Robin Crumpton is also here as a host, and so if there's technical issues, if you can send her a chat message as well, and she can assist. So thank you very much. I think we're ready to dive into one of our first discussions, and this is about the behavioral health workforce discussion. So I'm going to share a document that is just summarizes some of what the co-chairs of this working group had heard and what we heard from legislators following the discussion around the behavioral health workforce at the November, I think it was November 17th meeting. Hope I'm sharing the right thing. I think this is just going to be the agenda again. Let me try that again. Apologies. There we go. Well, I'm sorry. I'm trying to pull up this document, and every time I've been able to do it, and now I can't. Ah, there it is. Y'all see it? This is the top of the document is the recommendation from 2020, the Workforce Investment Plan recommendation. So that recommendation, for those of you on the phone, or if it looks a little small, I'll read it very quickly. The state of Kansas should make a long-term investment plan for the behavioral health system workforce by increasing funding for training, recruitment, retention, and support to effectively attract and retain high-quality staff. Specific steps include, and then the two steps that were provided last year were develop a career ladder for clinicians, such as through the development of an associate levels practitioner role, and take action to increase workforce diversity, including diversity related to race, ethnicity, LGBTQ, and the ability to work with those with limited English proficiency. So a discussion item for today is based on what the special committee and roundtable members heard in the November meeting and some of the key themes that were identified. We wanted to ask you all whether you'd want to, this working group would want to revise or modify the recommendation from last year to select one or more of the additional action steps that were included, or make any other revisions to this recommendation. Some of those themes that we heard included from members of the committee, they heard from you all heard from Beacon, a Nebraska provider that did worked with the state of Nebraska for a comprehensive plan. So one of the thoughts folks heard was the state should work with an organization that has developed strategic workforce development plans in other states to develop the comprehensive investment plan, including a focus on high school internships, mentorship, and free continuing education courses. One of the legislators brought that one up specifically as something that resonated from the presentation. Another item that also came up from what you heard about in Nebraska was asking in Kansas, the BSRB, to assess all licensing requirements to determine whether Kansas is at a competitive disadvantage. Another one was discussed, I believe it was brought up a comment about the rural residency track that is being developed for psychiatry at the University of Kansas. And this is through the Department of Psychiatry and Behavioral Health Services at the University of Kansas Health System. There's also the fellowship program we heard about at the Wichita School of Medicine as well. The current goal for the rural track residency is for first residents to begin in July of 2023. We also had some discussion afterwards from the legislators about seeding university programs to help develop and expand bachelor's and graduate programs in behavioral health, or creating a pool of funds that behavioral health providers could access to support retention. So these are options. There may be others that you want to talk about. We have only about 10 minutes to sort of talk about this overall, to think through, are there any of these recommendations or any of these options that you would like to add to the list from the previous recommendation of specific steps could include, and then add some of these? Or would you like to reference any of these just in the report rationale and the report background so we could add? Or is there any one or more of these that you would really like to call out specifically and highlight in this year's recommendation? And so I know we have a very short amount of time. It's a reminder that on Monday, we're going to be talking about finalizing the report. So we have to, if there's other ideas, we can include those as well, but we're going to have to do them in a pretty quick turnaround. Senator, I see you want to have something to add. Oh, I think you're still muted.
How about that? I'm sorry. When I read this thing, it says increased funding. My question is, what's our current funding? What's our current funding, and do we have any idea how much increased funding we're talking about? And then the second part of my question would be, as we develop this thing, have we been losing? We've been losing to other states. You hate to train people up and then they go somewhere else. So that was just a couple thoughts I threw into that. So.
Any thoughts from folks on the line, either from state agencies or others with experience with the workforce?
Carrie
This is
just did a.
Oh, go ahead, Joe.
It was Deb.
Deb, sorry.
So I'm really passionate about this topic. It seems to me that bullet number 1 towards the bottom there really is kind of a broader recommendation that could encompass any of the rest. It's been my observation that this is kind of how we've tried to tackle this workforce problem. And of course, it wasn't quite the crisis that it is now in the past, but just like our initial recommendation about a career ladder. Well, that's fine, and you can do that, but we are in such a dire need now that it really has to be a comprehensive approach. It can't just be, oh, well, this strategy or that strategy. And that's the things we've been seeing, in the legislative session. Well, let's reduce the requirements for social workers. Well, and again, those are good things, but it's not going to get us where we need to be to keep the workforce, even maintained, honestly. So that's my thoughts about that. And just under that, about asking the BSRB to assess the licensing requirements. I'm not sure they have the resourcing to do that. I would recommend that we talk about a legislative post audit for that purpose, or something similar, or contract with the university to do it, or I don't know.
This is Gary from ks, and I would agree with the first one, but I also think the bottom two, as we, when we look at this, at the current workforce shortage, it's affecting across the board, from the very frontline folks up to the professional staff. We have many areas that are at 50% open positions in those really frontline staff, and we can't serve people if we don't have the folks that the professional staff direct. So it's across the board. So I think if we could, I agree with number one, but I also think that the university programming to get folks involved in behavioral health, to attract them in that, but also the retention stuff and the last one are very important.
Thoughts from others? What I heard Deb saying, it does make sense to me that this first recommendation in many ways could encompass one or more, in many of the ones below, as well as previous recommendations. It's sort of a specific way to implement maybe the recommendation from last year, which was making the long-term investment plan. This is saying, hey, work on a strategic plan with this with an organization that's had that experience with other states, and then you're going to develop these strategies. And here are the kind of things that this group is particularly interested in. So what do we all think of potentially adding this language to your recommendation? Maybe including that first, potentially as the specific step. And then if you want to include any of these others, we could include that as well as those, or we could sort of call out as the very first step this year, and what's being changed is the idea of doing this initial comprehensive plan. What do y'all think?
This is Greg with Four County Mental Health Center. I certainly agree with every comment that's been made so far, but certainly the strategy of using the overall or comprehensive statement makes a lot of sense. And this will be a bit of a selfish plug, but from my organization's experience, I have a difficult time finding therapists, but I can find 3 or 4 therapists before I can find a psychiatrist. So bullet point number 3 down below has quite a bit of value to at least my organization. I'll let others weigh in on that. But for the long term, that's a tough one for us to get a psychiatrist located.
Gary, Representative Landwehr here. I think the thing I struggle with in both of those is the state should work with an organization that has developed strategic workforce development plans. Who and what does that mean?
I think we're saying beacon without saying beacon, Madam Chair. Beacon from Nebraska that talked with us when the committee last met.
Right.
So, Andy, I don't know if you want to chime in about some of the plans that the KDEDS has had perhaps previously around this kind of idea, even if you don't name a specific vendor. Yeah. Oh, I think you're muted.
So this is Andy Brown, KDEDS, and I agree. I think essentially we're referencing the Beacon model, right? Like Beacon is part of the University of Nebraska system, and they are working, to provide that expertise in their state. They have contracts that we've benefited from at KDADS by working with them through their training and technical center. But I think maybe to the representative's point, we might want to identify an organization within Kansas that could work with Beacon and become the Beacon of Kansas, right? Whatever that would be called. That way we're using our funds here and we're still benefiting from the expertise in Nebraska.
As long as it's Wichita State and not KU, I'm just saying.
Now, what's wrong with Kansas State University?
Okay, I'll put KSU in there and WSU, but no 2-letter university. Let's do it that way.
Oh, we'll let the legislature arm wrestle over that.
About what I'm writing here, I'm reflecting should work with a Kansas organization in collaboration with or learn from, or how would you want to phrase that?
Well, do we have an idea of who that organization is, and let's don't dance?
Okay, just name them.
Well, okay, we know Beacon's one, but who's the Kansas organization, Andy?
I would say it's unidentified at this point. Right, like we need to provide some funding to establish a program at a university. Is my opinion.
Who's we funding?
The great state of Kansas.
Does KDADs have extra?
We can examine that. I think. I think we have to figure out a little bit more about what would be required to establish it here, what Nebraska did to establish it in Nebraska.
Okay.
And maybe turn that into some legislation.
Well, but I think that's what we need to kind of clarify a little bit is to, figure out who we could get to work with Beacon so that we can develop our own Beacon, is what you're saying, right?
Yep.
Okay. Just figure out how to word that, Carrie.
I think we should identify a Kansas.
Establish maybe.
Establish a Kansas University partnership to develop. I'm going to develop the comprehensive investment plan, building on the model. What's the? I don't think that's the right. It's some sort of acronym like that I'll spell out that the committee heard about. Yeah. Does that make sense?
And then between now and the time that the committee, we might decide that we've got better wording for it, but I think that fits for right now.
Yeah.
And was there something else that we had funding in there for, Carrie? That the senator raised a question on, I believe Senator Fagg did, or was that on this?
Yeah, he gives the last bullet.
Perhaps on the pool of funds.
Carrie, those questions I asked, you could give that to me later,
Okay.
on that part.
Okay.
The thing I might want to add in at this point, that number 4 bullet, create a pool of funds that behavioral could access to support retention and recruitment. And here's my thought process. I'm the new guy on the block, and you're talking about Beacon. It'd be interesting how many people go through the Beacon program that stay in Nebraska. We don't want to be the ones paying for educating these people and they going somewhere else. And if we're in an immediate need, we probably need to be out recruiting, even if it's going to cost us some money and be more cost effective. So just my thought.
I'm going to stop sharing this for just a second, and then I'm going to drop that language into another document and see if I can. Yeah, go ahead.
This is Gary from KDADS, and that was, I mean, I fully agree with everything that's said on the first one, but that was also my concern, the immediate concerns that we have, that why I was thinking we should add the bottom one that we were just talking about.
The retention pool?
Well,
yeah. Yes.
Well, I'm Representative Landwehr here. I think where Senator Fagg was heading, I think that's always been our discussion anytime that we're looking at growing our own, is that we retain our own. And I think there's only any program that we design would have to have, you would only have some forgiveness of tuitions or whatever gets required if you do X, just like we do with our physician program in rural Kansas.
Okay. So looking at this recommendation now, and this is one of the times I'm going to move us along, even though this is an extraordinarily important topic. And we can return to this. We're going to have a wrap-up meeting, a ratification meeting on Monday this group is Monday at 1 o'clock. So, and you will receive a draft of this report sometime tomorrow. So you'll get all weekend to read it. Not only this, but other recommendations as well. And so we can return to those. We don't intend to make massive changes, but that could be an opportunity to revisit if people have other thoughts. Really quickly, I think I heard add this, but also add the retention and recruitment bullet item, as well as the university program bullet points. So we'll add those as well. When we do that, does that change anything about how the recommendation was characterized last year? It was characterized last year as, hey, this is going to be hard to implement because it includes program changes, maybe some pilot programs. Cost is certainly a barrier. Could require some changes in the legislative session, federal approval process, grant cycles, et cetera, because it could be a comprehensive plan. Yet it would impact a large population and impact multiple special populations. So it was graded as very difficult to implement, but very high implementation potential for impact. Do folks think that anything about what you talked about today changes those, sort of that assessment from last year? Or should we can keep that the same and just focus on the changed language?
I don't know that it necessarily changes it. It's a heavy lift because
yeah,
it's not as if Kansas is the only state facing this.
Right.
And again, we know that too, Carrie, we're going to have a benefit once our CCBHCs are up and running, but we're talking a year, 2 years down the road.
Okay, so unless I hear any objections, we will intend to leave sort of, we'll add the revision language. We'll add some discussion of why you all considered this recommendation so that, and we'll talk about sort of the long-term versus, hey, what we could do right away in the rationale discussion. But otherwise, we'll leave sort of the characterization the same. This had been considered a recommendation for strategic importance because it's not going to just take place tomorrow or be implemented tomorrow, even though it'll start soon. Does that still make sense for the group? I'm going to say that's a yes.
Yes.
Just to move us along. So thank you very much. That was a huge topic. We'll be able to flesh it out a little bit more on in the report that you see, and hopefully you'll see that reflected, and we can finalize that on Monday. So now we're going to shift gears and talk about some of the new and significantly revised recommendations where we had some feedback, and maybe there are a couple discussion items we wanted to look at. This was the recommendation that you all had talked about previously, so not intending to revisit the language, but just wanted to remind you all that this is requesting a legislative post-audit and then a number of bullet items to look at some of the best practices in other states regarding recruitment. So I think Deb or whoever had mentioned maybe LPA would be an option for even number one, that would be, that could be incorporated into the LPA request. So what we saw was, in general, this was viewed as we had different thoughts on whether it was immediate action or strategic importance. So let's walk through really quickly some of the ways we think about this recommendation. There was some difference of opinion among those who voted on this particular one about whether cost would be a barrier to implementation. With the LPA performing this audit, does the study change any of anybody's thoughts about whether cost would be a barrier?
I don't know that it changed. Representative Landwehr here. I don't know that it changes so much on the cost barrier. We just can't guarantee that we get a legislative post audit.
Right. So it's not a given that it happens, but it doesn't have it has the built-in sort of system cost of the LPA office, correct? Not an additional cost.
Exactly.
Right. So we're going to say no, but without a guarantee. I mean, if it needs to be done by somebody else, it would have a cost.
Yeah.
Great. And then the strategies for continuity, how does it consider sustainability? I think probably one of the discussion items that we heard from one of you in the response was, hey, we need to make sure that there's expectations about what's going to be done with this. What's the action that will be taken afterwards? So so that could be language that we include in the rationale that the working group intends to say it's not just a study that sits on the shelf, but it's a study that could help inform the work of recommendation 1.4 that you just revised, as well as the legislative process. Anybody else would like to add to that? Given all that, knowing that, hey, it has to do with the legislative session, I don't think it has the federal approval process for actually doing the study, but it would go through, actually implementing it would have some impact on all these other things, but the legislative session is the thing that would primarily impact the timing of this recommendation. What do you think the ease of implementation is for this recommendation, the actual execution of the LPA? And a reminder that the ease of implementation, 1 to 10, 1 means very difficult, 10 means, hey, this is going to be pretty easy. Something we could do right away. It builds on something we already have. And then we'll also score the potential for high impact. And that's not a lot of impact on not a lot of people to a lot of impact on a lot of people.
Carrie, Representative Land, we're here. So are you asking, I guess I'm a little bit confused on what it is that you're asking for.
So how easy is this to implement? The recommendation of requesting the legislative post audit and for them to actually perform that post audit. What's the level of ease versus difficulty? Thinking about the one you just rated above was the behavioral health workforce, comprehensive plan was very difficult. It was a 1, very difficult. How is this in comparison?
I would say a 7 or 8.
Yeah. Others agree?
I agree.
Potential for high impact. We say we had feeling that yes, it impacted a large population. There was some difference of opinion on whether it impacts people disproportionately impacted by the issue of related to access to psychiatry services. But there's thoughts that it would could produce savings in other areas as well. So what kind of impact do you think the LPA study itself would have? And this will help you. Yeah, go ahead.
Yeah, Representative Land, we're here. I think it depends upon what the LPA comes back with, Carrie. So that makes it here real subjective. So I would probably say a 6 or 7.
Okay. 6 or 7? I'm going to say 6. That makes it pretty subjective.
That's fine.
Yep. And the scores, we know, folks, we're not using that to like add together and come up with some master score. It's just to then help you guide through this, which is this a recommendation for immediate action or strategic importance? So immediate action is something that you could do and complete in 2 years. And so the lower the ease of implementation, or the higher that score is, the more potential for immediate action. But what do y'all think about this? Is this immediate action or strategic importance? We had difference of opinion on the survey. 4 said immediate action, 3 said strategic importance.
Well, it's kind of a little bit of both. I think it needs an immediate action in order for us to start making some very important decisions. So I would put it immediate.
Others agree?
Yes.
Sort of the action on this probably is the strategic importance, and that may be how some folks were interpreting it. Like what happens with it is what's going to be important. All right, thank you. The action lead, a quick question for the legislators. Who will take point on the recommendation? So who actually will request it? That has to come from a legislator, correct? Can it come from a committee? How does that happen with LPA requests?
I think a committee can do it, and if not, I would be happy to take the lead on that.
Okay. Committee or...
I also want to note that everyone should agree with everything I recommend like they have so far during the session.
And key collaborators. Looks like this is folks that have to work with LPA in the execution of this study would be, your agencies. Looks at KU is also being looked at, as well as what other agencies might be involved. KDHE, KDADS.
Oh, I think any agency that touches that, and then any of our universities that could be involved in that.
Yep, that's true. Well, I won't just.
We have more than one that does that. Yeah.
Yep. All right. Great, thank you. I think we have what we need on this recommendation. Let's go to the next one. This is the statewide psychiatric access program recommendations. So again, the I'll read it real quickly. Fully fund a statewide psychiatric access program that includes linked specialty teams with high levels of expertise. For example, psychiatrists, child and adolescent psychiatrists, peripartum psychiatrists, child psychologists, pediatricians, resource specialists, and patient and family advocates to provide multidisciplinary consultations to healthcare providers across the lifespan, including pediatrics and perinatal. Full program funding should be secure by 2023. Start with ensuring continuation of current programs. That was the language that you all had talked about before. He had the idea from most folks was for immediate action for this, that this requires, we had difference of opinion on whether this is a program change or kind of a building on what currently exists. This is the recommendation as written right now would extend the currently existing program that has federal funding that runs out in July of 2023. And then there was thought of longer term, there could be looking to expanding to other populations. Given that, what all do you think about the rationale or the ease of implementation of this recommendation? It basically says cost is a barrier to implementation. The answer was yes for most of you who voted on that as well. It got a unanimous vote for benefiting a large population. We had a comment that it may be significant costs associated with the recommendation, but fills a significant gap in the current state behavioral health network. So that could be a comment that we add to the rationale. The cost to this program is, if I recall correctly, around, in fact, I think Kelsey, you got me some updated numbers. It's slightly more than $1 million for the current program a year. Kelsey, we still have you?
Yes, sorry.
Okay,
Kelsey,
no, yeah.
KDHE, yes, that's correct. It looks like just short of 1.2 million a year to sustain the currently existing programs. If we kind of briefly discussed during a previous meeting, expanding the expertise that's available for consultation for some of our other more vulnerable populations. So of course, if we expand, there would be costs associated with that.
Okay. And this is actually a recommendation that will be takes the place of the frontline capacity recommendation last year, 5.3. So I went a little out of order in our agenda. So sorry if I surprise folks. So with that, knowing the cost, what do we think the ease of implement and the impact? What's the ease of implementation score?
I mean, I'll throw out a 7. Just because they're existing programs, although I don't want to discount, if cost is a barrier, cost is a barrier. I mean, I don't want to make it sound like money grows on trees, but we are trying to stick with it with existing programs.
And I'm sorry, I didn't realize I hadn't scrolled up. I scrolled up on a different screen than you all were looking at. So now you can see the recommendation I'm talking about.
I would agree on the 7. Representative Landwehr.
Okay. And how about the potential for high impact? Having a large population, kids, folks who don't have access to those services. How would you score that as well? Dr. Warren, you want to throw out a impact score too?
Yeah, well, what was holding me back on that one is I'm trying to think if it's expanded to all the full age range and conditions, for one, and then 2, if it expands its reach amongst the primary care providers. I mean, so in theory, if all those things go well, potential for high impact could be, I mean, really high, like an 8, but I don't know if I want to edge that downwards because that's not in place right now. I'm just not sure.
I think it'll have a high impact on the people it serves, but the global population, I'm not sure, because there's going to be a lot of people and only a small number are going to be seen, I guess, depending on how many people become a part of this team.
Well, so what I was thinking is that, I've attended these these are, you know, events that you attend to get educated as a primary care provider or as a, you know, mental health provider around Kansas. But it seems to be attended by the same, you know, set of people week in and week out. So I'm just thinking in my head, you know, if it truly did expand to be truly statewide and they had representation from all regions of the state and all age groups and conditions were represented, that's when I think the potential impact would be pretty high. If primary care providers across the state are being educated in mental health and learning to treat it, mild to moderate conditions themselves. But that's a lot of ifs.
If it's helpful for the pediatric mental health program, we currently have enrolled primary care providers in about 65 counties across the state. Dr. Warren's point, the training is definitely a small cohort of PCPs that participate in that, kind of on average between 15 or 20 per session, but significantly more use the consultation line services for that consult with our expert team. I had another point and lost it. I have a barking dog in the background. Sorry.
No worries. Well, Kelsey, what score would you give thinking about the current recommendation, which is starting with the ensuring continuation of the current programs?
I would say potential for high impact as it currently is would be maybe around like a 6.
Yeah, that's what I was thinking. I agree.
Yeah, what I'm thinking is like as it broadens the reach, the more PCPs that get involved, because they have a significant caseload, and then you assume about 20% of those patients actually served could benefit from, like, indirectly benefit from the program.
Okay. I think we can add that also to the rationale, that sort of the participation, and then as well as potentially expanding the program. All right, who's the action lead? Who takes the lead on this? Who do we say, so next year when they're reporting out on, has this happened? Is this KDHE?
I believe so.
Key collaborator? Sounds like it. Who else would be key collaborators? Or who would be key collaborators?
Currently, we work with the University of Kansas School of Med, both in Wichita for the pediatric program and then Kansas City for the peripartum program.
Okay. Okay. All right, thank you. I think we have what we need here. We had a question about, does it serve those who've been disproportionately impacted by the issue? And we had yes there. I think talking about the sort of the overall access, we'll look to our language that we provide and see if we need to do something else that reflects that. But I'm right now going to, in the interest of time, move us along to the next recommendation, which I almost did the same thing and only moved it on one screen. But now hopefully you all see Medicaid postpartum coverage. This was the recommendation to request the Bethel Committee review of extending the Medicaid postpartum coverage period to 12 months postpartum, supporting access to behavioral health treatment and other preventive care, improving health outcomes for mother and child. Some of the things we heard from the survey is that and follow-up information as well. There's a recent study that does reflect a little bit on Representative Landwehr, I know you said during the meeting, it'd be good to know sort of what's the cost of not doing it. And there's a recently published Commonwealth Fund study that we can reference in the rationale that actually talks about that at the national level, sort of what those costs are. So as part of that, you all had, the most of you all had considered this as designated for immediate action. But let's look real quickly through sort of the ease of implementation. This is requesting the Bethel Committee review, knowing what comes down the road. Is this this was for most of you because it was considered a request of review from the Bethel Committee, and it's in some ways a continuation of a policy that just because of COVID-19 is in place. It's a different Medicaid policy, as you all recall, is that women are disenrolled if they're not otherwise eligible at 60 days postpartum. but because of COVID-19, there's continuous eligibility. But it certainly is a policy change. So there's a number of boxes that were checked. There's a cost. The sort of the estimated cost was $10.5 million. Sarah, will you clarify? I didn't remember if that was SGF or all funds.
That would have been the SGF component, Carrie.
Okay, thank you. So, but it had a budget neutral to slightly positive effect on the CanCare demonstration costs. So with that in mind, what would you consider sort of the score for the ease of implementation for implementing this recommendation, which can now be done through a state plan amendment?
Okay. Well, Representative Landwehr here. Sarah, we're currently at what, 3 months?
For when postpartum coverage currently ends, Representative?
Yes, ma'am.
Yeah, currently we terminate folks the month ending 60 days after the date of birth.
Okay, so my question to you would be is how complicated if we were, because part of the reason that cost is so high is because that would cover all women, whether they needed it or not, correct?
Well, it would only cover those who are in the pregnant women eligibility group. So if you had a woman who was not in the pregnant women eligibility group, they wouldn't be affected by this policy change.
Right. Okay, I'm sorry, I needed to clarify that. So, but it would cover all the women that are in that group, whether or not they needed these services or not. And that's why the fiscal's so high, correct?
Yeah, it would cover everybody in the pregnant women eligibility group. There was a question, I think it was from Representative Lynn at a legislative committee recently asking if this would apply to individuals who miscarry, and it would. We have that information, and so women who miscarry, that additional 10 months extension would apply to them as well.
So this is probably not something that we can come in and put a qualification on it that, you know, that it only applies to those that actually need the services, because that would be too complicated and probably not approved by CMS. Is that right?
Well, Representative, there were a number of states before the American Rescue Plan Act was passed that created this streamlined option where states could just through a simple state plan amendment extend coverage to 12 months postpartum. There were a number of states who did smaller versions of this extension. So I think Missouri was one of the states. They did an 1115 waiver where they extended postpartum coverage, but only for pregnant women who had an SUD diagnosis. So much smaller population group. And CMS did approve that. So, I mean, the 1115 route is there. It's just a lot more time consuming to pursue, and you would have a separate budget neutrality standard for that. So the last tracker that I saw about where states are, a number of the states who are pursuing the 1115 model to kind of narrow down the population affected, most of them have pulled those back, and they're going the state plan amendment route instead, just because it's so much easier administratively.
Right. Well, this is the reason, and the reason I ask these questions. This is why I believe the decision belongs with the CanCare Oversight Committee. So we can maybe in our report is that we recommend that the CanCare Oversight Committee give this serious consideration and then decide what is the best path forward for Kansas. I don't think that we can, in the time that we have, Carrie, make a decision on whether, it's automatic 12 months. Do we do the plan amendment? What do we do? That's where Bethel has to do that.
Madam Chair, and that's what I'm sorry, go ahead.
Sure, I think that makes a ton of sense, Representative Landwehr. And one thing that I would note is if Kansas decides to go in this direction, this would be the first change to eligibility policy, really, that Kansas has enacted since CanCare launched in 2013. So to me, it seems very appropriate for Bethel to take a look at it.
Yes, so.
Madam Chair, that is, as currently worded, it does say to request the Bethel Committee review of extending that postpartum coverage. And so we can add some of that language that you just had as well about serious consideration and so on. And Sarah, I think it makes sense to note this would be the first change to eligibility since Can care began, oops, look at that, it autocorrects it into 2 words, in 2013. And so, and there's some other rationale we have as well from the previous discussion. Given that the recommendation is now requesting the Bethel Committee to review this, now how would we want to score the implementation? Because at this point, we're doing something a little different than saying implement. We're saying give serious consideration to implementing. So how would you score
Carrie,
that? Yes.
This is Cassandra Science. I think we need to also remember, I believe if we implement this for these moms who have these babies for 12 months, we're going to see less child abuse cases, less cases of children entering foster care, because these moms are going to be able to get the help that they need. Because if they don't have the insurance, they're not going to get the help. And I just think that that's going to save us in the long run. And we're going to have less kids with a lot of trauma. So, I mean, I think we're going to have those savings in there because of this.
I think we can absolutely add that. And that was some of what you all said in the response to, is that it first serves those that are disproportionately impacted by this issue. So this would impact some of the disparities in outcomes in maternal and child outcomes, and then produce savings in other areas. And I think that's what some of you had said as well, that this has some potential impact on the child welfare system, as well as just healthcare costs overall. And that's what the study we can point to also refers to. So, but that'll be something that would be referenced to the Can Care Oversight Committee per this recommendation.
Carrie,
All right.
Representative Landwehr here. I think
Yes.
that you make note of the potential for a positive on our net neutrality.
Yes.
And I want people to understand, we're not saying no to this,
Mm-hmm.
because I think if we had the authority, that we would say yes. But to expedite this in a quicker manner, it belongs with the Bethel oversight. We're just going to say that, we basically agree with this, but we know that the decision is with Bethel, not us.
Okay.
We're not saying no. We're not saying we don't want it. And I want people to understand that. But we're just not the right committee to say, yes, it's going to happen.
So with that, I'm going to try to get us to agree on what we think is the ease of implementation. It sounds like immediate action, because you're going to immediately refer it to the Bethel Committee. So the referring to the Bethel Committee doesn't have particular difficulty, does it? Should I grade it higher, or should we go with, should this be pretty much on the 9 or 10 scale? What do you think?
For immediate action?
Yeah.
9 or 10, but I think
for ease of implementation of requesting the Bethel Committee. Yeah.
Well, it's only easy, Carrie, if we take today, settle on language, and we have that language ready to be presented next week or the 13th.
I think it's
the 13th. We have this available or we get it to the Bethel Committee before the 13th.
Okay.
Otherwise, this isn't going to happen until sometime next session.
Okay.
Unless Representative Carpenter takes it up in his committee.
So I think you all, this group is going to meet on Monday to confirm and verify this report. The languages: request Bethel Committee review of extending the Medicaid postpartum coverage period to 12 months postpartum, supporting access to behavioral health treatment and other preventive care, thus improving health outcomes for both mother and child.
Yes.
Okay. So I'm going to put 10, but you guys can correct me when you are reviewing the report. So if we don't think so, because this committee, the special committee, will be meeting next Friday. But we could also note that the actual implementation is going to be more challenging than just the referral to Bethel Committee. Potential for high impact. What do we think the potential for impact is here, given a large impact on the large population, and then what Cassandra said about other impacts as well?
Representative Landwehr, I believe that's probably a 9, Carrie, but I want
Great.
this language as soon as you guys have it drafted, that we have it in a format to be presented to the Bob Bethel Committee. So someone from this committee needs to present that.
To the Bethel Committee? Okay, great.
This is Cassandra. I would agree with that. I think it's going to be a very high impact. I would say a 9.
All right, so action lead, who takes point on this recommendation?
I think we give it to Representative Carpenter. Is he on this subcommittee?
What's that now?
Is Representative Carpenter on this subcommittee?
I don't recall if he was on this one or
I
the
believe
other.
he was last year, but not this year.
I think he's on
don't
the
think
other.
he is. Yeah, he's not here.
Okay, and the key collaborators then would probably be information. So for the KDHE, is KDHE a partner in helping review this
Yes.
policy? All right.
Yeah, I think we dump it on Sarah.
All right.
Thank you, Representative. I'd be happy to have that dumped on me.
I kind of thought you would, so thank you.
Okay, we need to somehow catch up. So this is all very important stuff, but we are behind schedule a little bit. So we're gonna rock and roll through the next few. Is as important as they are. One of these was this. I don't think we need to revisit the language. We've talked about this before. Supporting the Kansas Suicide Prevention Plan, and this had the bullet points. Added additional information after the special committee meeting about what the $1.5 million in SGF to the KDAD's budget would support. We heard this morning, and a different working group heard this morning, that the $1.5 million actually would be part of the, as I understand it, and I can be corrected, would be included in what is funded by the 50-cent phone bill user fee. So that actually there's a funding source that's associated with that in the legislation that's going through for the 988 Suicide Prevention Lifeline. Please correct me if that's incorrect, but that's what we heard from Andy this morning. And also added some language about ensuring that KDADS, while it's the single state authority for the federal mental health and substance use disorder programs, it is collaborating with the Youth Suicide Prevention Coordinator in the Office of the Attorney General, and that the Kansas Suicide Prevention Coalition is leveraged to enable collaboration among all agencies engaged in suicide prevention. So that language has changed a little bit to try to reflect some of the discussion in the committee. With that, and you all saw this, those of you who did the survey as well. With that, I wanted to, unless we have an objection to any of that, we wanted to move along to look at any outstanding questions we had. This was considered for immediate action.
Carrie, Representative Landwehr, where's the 1.5 million come from?
From my understanding, and again, please correct me, KDADS folks that are on the line, that is actually part of the 17 point whatever million dollars that is from the phone, the cell phone user fee. It's in that budget. 1.5 million is included in that.
I guess I'm not following you.
So the 1.5 million, so the 988 Suicide Prevention Lifeline, if the 50-cent user fee goes on, it generates 17 million or so. Please, I hope Andy's still on the line to be able to fill this out. But the other working group actually had a presentation on this morning. Among the things that user fee would support was $1.5 million to implement these recommendations related to the state suicide prevention plan.
Yes.
So that's what it is.
Okay, now I'm with you because
okay,
I wasn't able to make the one this morning. So that, yeah, you're right.
Yep. That's my understanding. If that is incorrect, we will get that corrected but that was my understanding.
Thank you.
With that, we had pretty solid consensus on this recommendation. We have, let me see if we have anything we needed to resolve on the recommendation. We had strategic importance. We had almost everyone. We have unanimous votes. Some question about whether it's a program overhaul. Partly it was the data collection objectives will create additional challenges, but the rest of the recommendation could be, continuing to implement that and support that suicide prevention plan. So I think we have the information we need in general, but overall, what do we say for ease of implementation of this recommendation, which is supporting the key elements of the Kansas Suicide Prevention Plan?
I'll start the bidding at 5.
Okay.
I think he's probably right, Representative Landwehr, on this number. That would be around a 5 because it's not going to be a simple lift.
Okay. How about the potential for high impact?
Oh, I would say a 10, don't you think?
I would say, this is Gary from KDADS, I would too.
Yeah.
All right.
And I think the ease is right too. We've got a lot of this in the works and a lot of things are moving. It's just making sure we have the funding to keep it moving too.
Right.
This is
But
a
if
yes
more-
box. Go ahead.
But if more people don't start speaking up, we can just have me control everything, and I don't want to do that.
For the action lead, we did have the recommendation to call out KDAD sort of as a lead agency, but with these other partners, do we want to designate KDADS as the lead agency? Then with the other partners, including the Attorney General's office, KDHE, and all the other partners that are in the coalition?
Yes.
Yes.
All right. Thank you. Oh, well, I spelled coalition wrong, but it'll be there. Okay. Shifting gears now to talk about a recommendation that was a combined recommendation after you all completed 3 surveys, between the last meeting and this one. And one of those was to look at different options for trauma-informed care. We need to go through this one pretty quickly, but there were some questions about what it would mean to incorporate trauma-informed elements into KDADS and KDHE site visits. And so we would, in the rationale for this recommendation, also talk about the 3 original options that were proposed, suggest the use of broad-based screening questions that allow providers to demonstrate trauma-informed practices that meet the needs of their patients. And incorporate the dissemination of trauma-informed practices by behavioral health professionals to community partners and stakeholders. So with that, there were some questions just about that, what the site visits, what this is intended to mean. Dr. Warrens, I don't know if you want to talk about this, or if anybody, Deb, I think you had a question about this as well. The extra language here, does it help at all?
Yeah, the point of this was it's something that's up and running already and that this could be incorporated into it. I do understand some fear or trepidation by the providers on these site visits, which made me wonder about adding language that the development of the actual criteria that would be on KDADS and KDHE site visit protocol could be maybe developed in a work group that's where there's representation from providers as well as KDADS and KDHE. But then proceeding down the road of trying to have some broad questions that allow providers to flexibly answer how they are incorporating trauma-informed care in their clinics, understanding that trauma-informed care can mean different things in different clinics, and there could be multiple ways to do justice to that concept, that may vary from clinic to clinic widely. So the thought would be not to have prescriptive, too prescriptive, what I want to say, requirements that would force providers to do trauma-informed care the exact same way.
Deb or Lisa, any thoughts about that?
I mean, I'm really struggling with this one. And I don't know anything really about KDHE site visits per se, so I'll just focus on the KDADS. And I'm assuming we're talking about licensing site visits. Is that the type of site visits we're talking about that's already happening? Anybody know?
I would presume, Deb, that that's what we're talking about.
Okay. So right now, what they're checking for is all listed out in regulation or statute, right? So it's very clear what their charge is. And if you don't meet that minimum standard, then you're issued some sort of citation or corrective action plan or whatever. Implementing evidence-based practices is a completely different animal, if you will. Frankly, that requires total buy-in from the top all the way down. It's a long haul. It's more of a marathon rather than, you know, I can check this box and then move on till the next time you come kind of thing. So I guess having done both for a long time, I don't know that I feel like incorporating this into site visits is going to get us where we want to be. So that's my 2 cents.
Is there a revision that would preserve some of the concept of basically, hey, being when the state is interacting with providers, talking about how those providers are implementing trauma-informed care in their practices would be part of the discussion. I think that was probably what
Yeah.
the
So
evolution is. Is there something like that that the group would be
I'm going to be
comfortable with?
blunt. I'm going to be blunt. So the state staff are not, I mean, I don't see them attending a lot of training. I mean, you would have to train up these people to be basically almost serving in the technical assistance type way. I mean, providers have to feel like the state staff know more than they do about implementing best practices. Otherwise, what is this for?
Right.
Am I going to get a demerit? Am I going to have to write I mean, implementing best practices, you're moving into the quality realm rather than the compliance realm. And that's just a whole other animal. There has to be incentives. Providers have to want to do it. It has to be financially feasible. They need resourcing in order to do it well. I mean, we talk a lot about this. I have to write it on things all the time. What evidence-based practices are you using? Now, nobody kicks under the hood and says to Fidelity, who's coming in and checking Fidelity? Why? Because that's expensive. We're not funded adequately enough sometimes to do the job, let alone to actually go out and get evidence-based practices done that well into our facility that someone else is actually looking at it and saying, hey, well, how are you doing? Now, not to say you couldn't develop that with state staff. Right. I don't know that it's licensing staff. Maybe that's a whole other, you know, realm of people that work in there, and that's what they do. They go out and get that training. They have that expertise. They can provide education, and they could do some of those checks for providers who have, you know, pursued this. But I don't know how you're going to like make them do it at this point.
So I see from both Deb and I've seen a couple other people sort of nodding along as she's speaking that probably this language is not what you all have a consensus around. Is there any in the survey? There were 3 options, and basically they all had equal votes and sort of equal support, and they and then there was also some talk about, hey, could we combine them? And this was a suggestion the co-chairs worked on to try to figure out a way to do that by building on something that existed. So an option is to remove this as a recommendation, but have a report discussion around the alternatives that you all had talked about and sort of the importance of trauma-informed care. Unless you find that there's one from the previous recommendations that you'd like to do. Given the time we have, which is 20 minutes left in this meeting and then an hour on Monday, it might be a challenge to come up with a brand new one, but it is up to you all. And know that we still need to talk about social isolation, stigma, MAT, foster homes. That's mostly it in the next 20 minutes.
All right, we do have the evidence-based practice subcommittee to the Governor's Behavioral Health Planning Council, and maybe that's an organization that could help with wording and structuring this particular recommendation. Charlie, I don't know if you want to add to that, but that may be a possible answer to our questions around this one.
This one's a little difficult because it's not exactly an evidence-based intervention, like a treatment intervention. So,
but I do agree with Deb. I mean, surveyors are going to want a regulation What am I looking for? There's no correct answer. There's no, there's not much to regulate there. And we do have other visits to facilities, but we're not going out to ask about trauma. I mean, we do have those discussions, of course, that comes up, but we're not ranking anything in a visit related to their trauma-informed abilities.
So,
real quick, my thinking was that really pilot projects would be the most helpful. Figure out who's already moving in this direction, get their buy-in, get them to help go in and do some sort of evaluation. I'm not sure who does that. Have that discussion, what's missing, what's helpful, how can we move the needle along this, and then apply whatever those lessons learned more broadly.
Or even having them demonstrate that they have trauma-enforced training within their organization.
Okay, in the interest of time, I'm going to call this one, and then what do people think about the general concept of what Gary and Deb were talking about there? And we'll just have to place some language in the report and have you all react to it, but by Monday, which is just to perhaps as a recommendation or as a discussion item in the report, saying this is the group is interested in this work continuing and potentially building upon those entities that have, that have developed trauma-informed practices to be able to help disseminate those among the other providers, but then also the broader community.
Yeah, and this is Charlie with KDAS. I would tend to agree with what David said about being a quality issue, and it might be with putting together pilot or a work group that could be convened by KDADs that would bring together some providers and those that are currently implementing, and then make a recommendation that could come through the Evidence-Based Practice Committee of the council, and then look at that for future accomplishments.
Okay. Is there general concurrence with that idea? The work group? Make recommendations?
I'm good with it.
Okay. I think many of the evaluations you had about what could be done here, this would look more like a pilot program now, but otherwise your impact on the community would look very similar. So I think we have some good marching orders for what we want to do moving forward. And that sounds like it's KDADs. Yes?
I just want to comment on that. We do have a program here at Osawatomie State Hospital, and Kansas is one of 4 states that was picked for a trauma-informed care project. So we do have some really good things going on here, and working with KDADs, and then the Evidence-Based Practices Subcommittee has done a tremendous amount of work. I really think the council can do a really good job of putting something together that we all could agree on and build on.
Thank you, Wes. I'm going to shift us gears only because we have 15 minutes left and we have quite a little bit to do. So, and I'm going to do this really quickly. The recommendation was promoting social isolation as a public issue, creating strategies. This actually merged 2 recommendations, creating strategies to disseminate the importance of social isolation as a public health issue, using social media and media campaigns, educating providers, and encouraging adoption of a screening tool. A question for you, I think we have the overall feedback. A question for the group is, based upon what exists now, sort of as in prevention activities, who would be the action lead? Is this something that we're saying KDADs, hey, help do this, or is this KDADs working with KDHE? Social isolation has impacts beyond behavioral health as well. Lisa, are you saying something? You're muted if so.
I am just totally agreeing.
Okay. Thanks. How about for, I'm going to.
Gary, this is Gary. I would agree that we have KDADs and KDHE involved in that.
Great. We had a sort of a mix on strategic importance or immediate action. What do you all think about this? This is creating strategies to disseminate the importance of social isolation. So is that something that can be done and completed, started and completed in 2 years, or is this a longer term project?
I think it's longer term personally. I mean, you look at what it took to even get everyone familiar with the symptoms of heart disease, right? This is not a one and done.
Strategic importance still says start right away, but it's going to take longer to fully implement.
I
Okay.
would agree with that.
Do
Yeah.
folks agree?
Yes.
Okay, cool. Thank you. And I know I'm really rushing y'all now. This was the recommendation about the stigma, which is this is a broader recommendation. It's basically in lieu of discussing stigma, really try to use and promote success stories like the 988 Lifeline Mobile Crisis CCBHC model to publicize behavioral health as health. Really talk about health, creating a culture, and then this language is adapted from the American Psychiatric Association. That was one of the recommendations you all gave us. Creating a culture in which mention of depression, anxiety, post-trauma addiction, and other common illnesses become as mentionable as diabetes, heart disease, and migraines. This is sort of higher level, right? This is kind of like maybe the action lead is everyone, right? But so with that in mind, I think the main thing that we wanted to get some feedback for you on is who would be responsible for, oh, we already did that on the other one, but I would say the same thing here. Who would we consider sort of responsible for helping guide the way? Is this a KDADS helping guide the way, or is it KDADS and KDHE? Who's your action lead?
I think it's another combination. This is Gary from KDADS.
Okay.
So KDADS and KDHE.
All right. Folks agree? I'm going to skip the ease of implementation so on, since we already had the designation of that being immediate action. We might ask you to fill that in on Monday. Now, so we were complete with those that were new and significantly revised. I will let you know that there were two recommendations, community-based liaison and behavioral health prevention, that had pretty minor changes. We talked about expanding the locations where community-based liaisons are available to facilitate connection to treatment. This was validating that the upcoming CCBHC model would address the concern about fee for service, but then there's other providers other than those that qualify as a CCBHC that would benefit from the community-based liaison, and then increasing state funds for behavioral health prevention efforts. And there was some discussion about the committee question about the detail on funding. If workforce is an issue in primary prevention and community prevention activities, we may have to discuss that a little bit Monday, but the language that you all had was just to support additional evidence-based primary prevention and grant opportunities for community prevention activities. That was just specifying a little bit more what the prevention plans would be. The other two elements we had were a discussion that we had previously around MAT and foster homes. So I'm going to open up a separate document. We see if I can do this quickly. Well, and this is to look at potential change in some language around, I think this is correct. Yeah, we already talked about the first one here was the medication assisted treatment. So the recommendation from last year was increasing capacity to access medication assisted treatment in Kansas through provider training on MAT. There had been some discussion of revising the recommendation to address other issues. The working group has the option to leave the recommendation as is, but add some report language or select one of these elements to add to the recommendation. And one was a suggestion to require MCOs to report regularly to the Bethel Committee regarding network access to medication-assisted treatment services. Ensuring that the CCBHCs will be allowed to collaborate with SUD providers for MAT as well as other SUD services, and ensuring funding sustainability for MAT if and when federal opioid grants end, which that's a current funding source that doesn't have a set end in sight, but also doesn't have a time immemorial sort of timeline on it either. So thoughts from the working group about whether to modify the recommendation or just add some language to the report about the importance of the three items here, one or more of these three items here. And we've got like 2 minutes to decide. Any preference?
Carrie, it's Deb Stidham. You know, I made the comment in my response on the survey that the alcohol and drug field per se is woefully underfunded, has always been underfunded. The majority of clients seeking treatment for alcohol and drug services in our system have no insurance, have no Medicaid. They will not qualify for Medicaid. And until that kind of elephant in the living room is just fully acknowledged, we're going to struggle implementing MAT fully in this state.
Thank you, Deb. And that can be part of the discussion language too. So I don't hear strong advocacy for adding any specific element to the recommendation, but we could add these discussion points to the report just to reflect what the committee had discussed or the working group had discussed. Is that reasonable, or does somebody have a different feeling?
Yeah, I agree with that. I mean, I think there's some really good recommendations buried in here, but I think we're pressed against the wall time-wise, and so to have them not be lost, I think I'd be in support of, you know, making sure they get incorporated into language.
Thank you. Finally, a similar one, foster homes. The recommendation last year was the state of Kansas should invest in foster home recruitment and retention by increasing funding for supplemental training on behavioral health needs and providing additional financial incentives to support serious emotional disturbance, SED, youth. In this year's discussion, the first meeting, you had some working group members that felt the recommendation should be modified to include ways to improve systems to support foster families. So not just about improving the foster families or the training for foster families, but also improving the systems they interact with. The working group has the option to leave the recommendation as is, but add some report language to that effect, that what you all had discussed, or select one or more of the elements below. There was some discussion. KHI was asked to reach out to DCF to have some discussion around some specific elements that could be added either to the report or to the recommendation. So here are 4 examples. Supporting families navigating the child welfare and Medicaid programs. It's a recommendation that's come up in other working groups as well, sort of that navigation services. The Autism Task Team, for example, is looking at that as well. Continuing investment in recruiting, preparing, and supporting families to serve high acuity and older youth, as well as recruiting, preparing, retaining, and supporting African American families because of the number of African American youth in the program. That's already underway, so that would be sort of supporting something that the organization is doing. Providing in-home therapeutic parenting services for families to meet high acuity needs. That is described as an ongoing goal that's doable, but trying to expand the evidence-based programs, or ensuring, and then the big one, the big picture, is the ensuring services are available across the continuum of care for youth discharged from inpatient or PRTF settings. So that has a broader sort of inpatient and PRTF applicability as well. What does the groups thinking about whether to add any of this language to either the report or to the recommendation?
Well, Gary, this is Gary from KDADS, and being the child youth director of behavioral health, I almost want to add all of it. I really think that it's very important. I also think it's important that we have something in the discussion about making sure that we're treating foster families as families, and families in general, broadening that definition of family, and making sure that we're including them in all services. But you know, we just can't. I don't know how you take any of those out, and from where I sit in my, you know, with the things I'm dealing with on a daily basis. I'm not sure. I imagine Brenda has a comment on this too.
Well, actually, this is Brenda from DCF, the Director of Medicaid and Children's Mental Health. And I would agree, Gary, and actually these points were the things that Carrie and I and a couple other people at DCF discussed. And these are our top 4 that we would say are the most important. And that would fit here under this recommendation. So we are, my group, there's 2-3 of us, we are working on some of these things currently, looking outside of the state at what other states are doing. Gary, you were involved in a call with Missouri and we're looking there. Yeah. So it is ongoing, but we would support adding these to this recommendation.
An option for the group is we could add these 4 elements as because you already had a by increasing from in the previous recommendation, and then add these as the additional bullet list items. And we would have to then probably revisit whether you wanted to change a different implementation score. There is a fairly high ease of implementation score that was given previously for this, because the focus was specifically on increasing funding for supplemental training. So this would maybe be a little different. And the potential for impact is probably very similar. That was a 7. If you were to score the ease of implementation of doing all of these things, how would you all score this? And we've got like 30 seconds to decide.
What was it before, Carrie?
8, but it was only about increasing funding for supplemental
Sure.
training. Now it's going to be
I
all these
think
things
we
as
need
well.
to be about a 5.
Okay. And it was a 7 for potential for high impact before.
This is Brenda with DCF. I would agree with Gary's 5, and I'd say it'll have a high impact for foster care. But when you're looking at all the other populations, maybe not as much. So maybe a 6, 7.
Okay. That's it. Yeah, it was at 7 before, so that's what makes sense.
Yeah, I'm okay with leaving it at 7.
Okay. All right. And I think we still have the same lead agencies there, DCF and KDADS. DCF is action lead.
The higher means the more. I mean,
Yes, correct.
Just to make sure I'm clear.
Yeah,
okay.
That's correct. Okay. Well, we've got 3 minutes left. We're not quite done though. So a reminder, a couple other issues that that you had heard from, and Dr. Warrens, I don't know if you want to talk about this, that there were reports from the Autism Task Team and then the Governor's Commission on Racial Equity and Justice that were provided to the special committee, and then also in the case of Autism Task Team, to the working group. So hasn't been a specific separate recommendations developed for autism. The Autism Task Team now its report is going to be submitted in January. So the co-chairs had discussed this report referencing, and sort of not as a recommendation, but as a reference to other work being done, pointing to the recommendations of the Governor's Commission on Racial Equity and Justice, which in the past have been crosswalked with this committee's reports as well, recommendations as well, and the Autism Task Team report. So unless folks feel differently, that is going to be what you'll see in the draft, is sort of a cross-reference to that other work that's being done in other working groups and commissions. Good? All right. Somehow, by rushing you quite a bit at the end, and I apologize, we're exactly on time. So, or we have 2 minutes left on the agenda for administrative updates. And I do apologize. I know that was so much to get through in the time we did, but you all were very helpful, and I think we got a lot done today. And hopefully we'll be able to reflect all that in the report you see. So we will be sending the working groups. The intention is to send you the draft report tomorrow. And the goal initially was going to be just sort of the guts of the report. So those tables that we were looking at, the recommendations, the rationale, and sort of some of the ease of implementation considerations. We may or may not be able to send the whole report, which includes some of the pre-matter and some of the appendices as well for your review. We will do that on Friday, and then on Monday, all of the working groups, including this one, will be meeting. This one will be meeting at 1 p.m. And at that point, we're going to be ratifying the report, ratifying your section of the report. You will see the entire report, so you'll get the report that has all of the recommendations, even the ones the other working groups have been working on. It's a little more complicated maybe than last year to look at, because there's not just a section that says services and workforce working group, because some of the recommendations that you guys looked at were numbered differently last year. So to try to preserve continuity with last year's report, everything's presented in the numeric topic order, but we'll have some instructions for you. Basically, it's pretty straightforward for you all. You just have like one recommendation. 2.4 is the suicide prevention one, that otherwise topic 2 is in the other working group. But there'll be some direction on that. You're welcome to look at the whole report, absolutely. But then come ready to talk on Monday about finalizing the report. We're not going to go through each individual recommendation, just look for anything that we missed or changes that need to be made. And then discussing any Any issues that you would particularly like to be able to talk about to the special committee, because it will be presented to the special committee next Friday. So it's a rapidly moving vehicle, but thank you for all of you for keeping us on track. Any questions about that plan?
Just a small one, Carrie. Our co-chair meeting tomorrow at 8. I just don't know if we need it or if we don't need it.
Let me know. Do you need it? Let's do a half-hour one.
All right.
Okay. All right.
Have the invites for Monday been sent out? I don't seem to have that on my schedule at this point.
No, I think those will be generated after this meeting, and so those should be distributed either later today or tomorrow. It might be distributed with the reports tomorrow, but please place that time on your calendars. But then you'll get the message from KLRD with the links to the meeting.
I've got my whole day says mental health modernization with a few other things, but I just wanted to make sure I wasn't missing something.
Yeah, that's my calendar too, Gary.
Is the time going to be 1 to 2:30 again?
No, it is just 1 hour. It is 1 to 2. We have just 60 minutes on Monday, because we're just finalizing. Yes, 1 hour meetings. And hey, with all the work you guys got through today, maybe, famous last words, maybe it'll be even less than an hour. All right, it's 2:32, not exactly on time, but pretty darn close. Thank you very much, everyone. Have a great rest of the day and a great weekend. Let us know if you have any questions when we send you the report. Bye-bye.
Carrie.